Hello? Hello?
Hello, Chikosa. You can start now.
Hello?
Chikosa, we can hear you.
Hello? Hello?
We can listen to you.
Oh, you can hear me?
Yes.
Okay. I think I have an unstable connection. Can you hear me now?
Chikosa, if you prefer, you can off the cam and only be able to the microphone.
Okay. But you can hear me now, eh?
Yes.
Okay. Is Lonias there?
Yes, Chikosa, I'm in.
Oh, you're in. Tapiwa?
Yes, I'm here.
I guess we can get started now. Oh, wow. Not working. Anything is not working. It's very unstable. I guess we can get started.
Yes, Chikosa, we are waiting for you actually.
Hello?
Yes, Chikosa, you can start now.
Yeah, I think I have a very unstable connection, so I'm not sure how I go about it. But we can get started. Yeah? If I can be heard, then you can get started then.
Yes, we can.
Okay. Good morning and good afternoon. My name is Chikosa Banda from Malawi, and my co-panelists are Tapiwanashe Kujinga, who is the Director of Pan-African Treatment Access Movement, and Lonias Ndlovu, who is the Dean of the School of Law, University of Venda. Our panel is on production of medicine in the Southern African Development Community and SADC, and COVID-19. So I guess the other panelists will introduce themselves, but I should just get started with what we are looking at. We are looking at the advent of COVID-19 and the implications it has had for access to medicines in the Southern African Development Community region. The issue is that since the advent of COVID-19, one thing that has been clear is that the need for SADC countries to avoid over-reliance on imported pharmaceuticals and diagnostics has been exposed. What has happened is that the SADC member states have very much relied on medicines from other countries and medical commodities from other countries, including India and China. And since COVID-19, we have seen disruptions in that supply chain. One thing about COVID-19 is that it is distinguishable from other public health crises because it has disrupted almost every aspect of human life, including the market. And the other thing is that has been characterized by the sudden onset and rapid spread. And then
Chikosa, we lost you.
So we seem to have lost Chikosa. I suggest I have got his presentation here, and I propose that I could then just read through the presentation. Would you, the control master, would you have Chikosa's presentation for uploading? Or can I do it from here? Hello?
You can share.
Thank you. Is the presentation now visible?
Yes, it's visible. Can you please up the volume of your microphone?
Yes, I think I may just also have a problem with the volume of my microphone. Let me speak very close to it. So the topic for Chikosa's presentation is production of medicines in the SADC region. So, as Chikosa was saying before we lost him, the COVID-19 pandemic has actually exposed the need, for SADC countries to be self-sufficient and not to rely on imported pharmaceuticals, diagnostics, and other therapeutic commodities from foreign sources such as China and India, and has also made the case for local production of essential medicines, vaccines, medical equipment, and diagnostics. So the COVID pandemic basically is distinguishable from other pandemics because of its disruptive nature, and that it had a very sudden onset. It was not anticipated. The rapid spread, the absence of a cure or vaccine, and then shortage of critical supplies, and massive market impacts. So the barriers to availability, affordability, and accessibility of medicines and other medical supplies. The disruption to the value chain of production and consumption across different sectors was very evident, because then we had imposition of national lockdowns and shutdowns of some manufacturing plants. We also had extended factory closure. We had export bans, restrictions of free movement of goods and people, logistical challenges. And then all these factors had a negative impact on the availability, affordability, accessibility of medicines and medical supplies. In that the cost of some of the key medicines rose, as well as diagnostics. There was also a disruption of the supply line and distribution, and then inevitably there were stockouts. So the pandemic has shaken global solidarity in healthcare and triggered health care nationalism, and it exposed the vulnerability of the SADC region. It made it so difficult for countries to source more medicines, equipment, and diagnostics from outside Africa, where most of these commodities are sourced. But also, it provided an opportunity for SADC states to reduce their dependence on imports. And to do that, they should gradually wean themselves from dependence on outside suppliers, close the supply-demand gap, and then implement the SADC pharmaceutical business plan, which calls for greater scaling up of local pharmaceutical production. It also exposed some critical issues relating to intellectual property rights and the public interest, and the need to then ensure that intellectual property rights do not create barriers to local production and rapid access to medical products. So what have been the implications? The COVID-19 pandemic strengthened the case for the creation of viable local and regional production base for medicines and medical technologies, as well as the maximum use of TRIPS flexibilities to stimulate and support local and regional production of medicines. And also considering that intellectual property right restrictions and the uncertainties on intellectual property rights may frustrate research and development, as well as the development and manufacture and distribution of generic medicines and other crisis or critical innovations, which include ventilators, testing kits, PPE, and other medical supplies. So the creation of a viable production base is largely dependent on a policy space, which facilitates the acquisition of intellectual property protected new technologies, and as well as access to technology and know-how. So the proposed intellectual property related responses to the COVID-19 pandemic, which we've recently observed. So over the last couple of days, we've had the release from WIPO that India and South Africa have requested the WTO TRIPS Council for a waiver from the implementation, application, and enforcement of certain provisions of the TRIPS agreement, insofar as they relate to the prevention, containment, and treatment of COVID-19. These provisions relate to copyright, industrial design, patents, and protection of undisclosed information. And they've also been called for global solidarity and unhindered sharing of technology and know-how, as well as the waiver to continue until the vaccine is widely available globally. And we've also been informed over the last few days that least developed countries have submitted yet another request for an extension to the transition period for implementing the core provisions of the TRIPS agreement by 12 years from 1 June 2021. So what are the factors that hamper the use of the flexibilities as things stand? So there are a number of barriers to the use of TRIPS flexibility in the SADC region, which include the workings of the ARIPO patent system, which does not fully support the use of the flexibilities by countries within the region. So ARIPO is the African Regional Intellectual Property Organization, and if memory serves me right, there's about 8 member states of ARIPO, which are also SADC member states. So the ARIPO system is designed in such a way that designated members routinely accept patents. It does not recognize LDC waivers or transition periods. It fails to apply rigorous standards of examination. It has got lax application of patentability standards. It does not prevent patent evergreening. It allows secondary patents, new use patents, and combination claims. And it also lacks administrative opposition procedures. So countries have also been slow to update their laws to take full advantage of the TRIPS flexibilities to promote local production. And other institutional and legal challenges include the cumbersome and lengthy procedures associated with the Article 31 bis of the TRIPS agreement. One of the things that we need to take into account is that the flexibilities are not a panacea to the challenges that have been identified. But the use of the TRIPS flexibilities and the waivers per se, right, will not solve the problem. There's an urgent need to promote local production capacity. In other words, it's something that I'll talk about in my presentation. There's a need to build an efficient and effective pharmaceutical manufacturing industry. So even if countries take advantage of the flexibilities with a very low local pharmaceutical production base or capacity, then the use of the flexibilities will not be impactful. So Chikosa is arguing for the urgent reform of the ARIPO and the domestic patent systems in order to eliminate the barriers to the use of the flexibilities by SADC member states, as well as the implementation of non-intellectual property related policies to stimulate local and regional production. And it is then hoped that these reforms will stimulate local production of generics and intra-regional trade in pharmaceuticals and diagnostics. Thank you. So this is the presentation which Chikosa was supposed to present. And I will stop sharing and then ask for questions. Thank you. Any questions before we go to Lonias' presentation? Thank you. So it means that we don't have any questions from the participants. I will then ask Professor Lonias Ndlovu to then take over with his presentation. As Chikosa said, Professor Ndlovu is the Dean of the School of Law at the University of Venda in South Africa. And his presentation is IP and local production, the potential role of the TRIPS flexibilities. Professor Ndlovu, you have the floor.
Thank you, Tapiwa. Good morning and good afternoon to everyone in this webinar. I am going to share my screen quickly. I would assume at least everyone, I would assume everyone can hear me.
Yes, we can.
Oh, thank you very much. Let me just share then my screen. Let's I have already been introduced, so I would want to thank my colleagues for their earlier presentation and actually preempting what I was going to be talking about. I have just 5 slides. I want to highlight a few issues in the context of TRIPS flexibilities and local production. The point of departure is that my presentation focuses on TRIPS flexibilities and how they can actually aid local production. I'm not discussing all of them, but you will notice I do try to explain what these are. I see sometimes in such discussions, it is not always a good thing to, dive into the explanation, unless, of course, one has an idea what the audience is like. But I'm looking at these and saying, when we're looking at these flexibilities, it's quite a widely written topic, a topic that's widely written on, and examples you can see, the widely cited ones are the patentability standards, compulsory licensing, parallel imports, and others. And of course, there's quite a constant reference to the Doha Declaration and how it works in favor of developing and least developing countries, and the Southern African Development Community consists of developing and least developing countries, and actually least developing countries dominate the region. And I'm looking at it and saying the region has been aware of the need to locally manufacture essential drugs. And I'm saying the advent of COVID-19 has made the situation quite desperate, but calls for local manufacture have been going on for quite a while. We talk of the pharmaceutical business plan and issues around pooled procurement. The region has been seized with those for quite a while, but we haven't seen a lot of progress actually happening. The other issue we should acknowledge is that although in our presentation we're talking about the Southern African Development Community going more into the sphere of local manufacture, pharmaceutical manufacturing capacity in the region is quite limited at the moment. And in a 2014 UNAIDS study of 21 African countries in the Southern African region, South Africa was identified as one country which has a potential to actually manufacture, and supply the region. And the capacity there is, although it's modest, but it is some capacity to note. And I'm simply saying that point must be factored in, that my manufacturing capacity is quite limited. So what we are proposing, or what we are desiring in terms of this presentation, must be implemented taking that limitation into account. So I do make mention of these flexibilities. The list really, but my presentation is not focused on all of them. I'm just going to show in the next slide that I'm just focusing on 4 issues. But I would want to just say, for the benefit of everyone listening in, that where on that slide that you see, where I've included provision, I'm looking at the provisions of the TRIPS agreement. It would have been a good idea to actually look at the individual laws of the different SADC countries, but this presentation doesn't go that far. The issues I'm focusing on in this presentation are these. When we're looking at local production and the TRIPS flexibilities, I'm saying the TRIPS flexibilities that one can consider as low-hanging fruits in the context of the Southern African Development Community would be patentability criteria, the LDC exemptions. I think it's a typo there where it looks like it's LDC exemptions. No, the LTD is limited exceptions, my apologies. And then LDC transition period, and then compulsory licenses. A few remarks are opposite there. I just want to say, when one looks at most of the patent laws of Southern African Development Community countries, one will discover that all of them actually do make provisions for the protection of products, processes, and pharmaceuticals are really not exempt. But then when one looks at the requirements for patentability as spelled out in Article 27.1 of the TRIPS Agreement, it is quite clear that each country does have its own policy leg room to decide what amounts to an inventive step, what amounts to novelty, what amounts to utility. And we are actually saying, if these Southern African countries can, in their domestic legislation, make provision for stricter patentability criteria, this can actually spare local production, because that would actually mean the local companies are not squeezed out, through competition coming in from products from outside, which are not really necessarily patentable. And I'm saying one other area in the context of COVID-19 we can zero in on is when one looks at the drugs that have been touted in the media, in academic writings, medical journals, and elsewhere about the possible cures for COVID-19. Most of us would remember drugs like favipiravir, chloroquine, and hydrochloroquine. Trump was very upbeat about chloroquine earlier, in media reports when the COVID-19 pandemic started. When you look at these three drugs, I'm just isolating them here as examples. When you look at them, they are not new drugs. Right? They're drugs that have suddenly found a new use or new uses in the context of COVID-19. And I'm saying this is a window of opportunity where we are saying, should it happen that clinical trials confirm other candidate drugs as possible cures for COVID-19, then it is an opportunity for Southern African countries to actually use, the flexibility relating to limited exceptions and ensure that, they apply their domestic legislation in such a way that new uses of these drugs are not considered as patents, and then they don't hinder possibilities of manufacturing generic versions of these particular drugs. That's one area I see as a window of opportunity. And then, of course, the LDC transition periods themselves, where we are aware now, at least developing countries are asking for an extension of the 2021 concession that they obtained earlier. And we are actually saying it is still possible for at least developing countries to, not to protect patents. And as I said, as I highlighted earlier, 9 SADC members out of 16 are least developing countries. And when one goes to the next point that I'm talking about, where we're talking about compulsory licensing, I am saying Article 31B, although my colleague earlier said it is a cumbersome process to implement in the domestic context, but its full extent, it should be used. And I'm saying Article 31B of TRIPS is it gives one quite a good window of opportunity for countries, in a similar situation like those in the SADC region, where we are saying where there is at least 50% of the countries being LDCs, it is actually possible for a developing country member of that region like SADC to allow the manufacture of required drugs in its own backyard and then export those to other countries in the region which share the same disease burden or the same health problem. And we are saying this provision of Article 31bis, which basically is largely referred to as the economies of scale provision, is another window of opportunity the SADC region can actually take advantage of. With Article 31F of the TRIPS agreement, where compulsory licenses were supposed to be for the predominant supply of the domestic market, Article 31bis came in, remedied that to some extent, and it is now an opportunity. The challenges that my colleague mentioned earlier, we are saying these are, possible windows of opportunity that may be used. And then, colleagues, I don't want to, but I just wanted to actually say the theme we're talking about today is local manufacturing in the SADC region of pharmaceuticals. And then I'm looking at how the TRIPS flexibilities can be used to aid local manufacturing. On this slide, I'm basically highlighting or summarizing some possible, solutions out of the shortage of drugs in the region, as was highlighted by the first presenter, where I'm actually saying, if reform happens on the legislative front and laws are adapted to really impose some strict patentability criteria, this, as I highlighted earlier, will aid local production in that these established pharmaceutical companies will no longer be able to just bring in their drugs that are really have been produced, under context in which evergreening has been taking place because the patent laws are weak. In this particular case, once we have a stricter patentability criteria, it actually means that the room for local manufacture is created for local producers. And I don't want to ever emphasize that Article 31bis now allows for local production in order to supply the domestic market and also local production for export in different inappropriate contexts. And then the prohibition against new use patents, which I highlighted earlier when one looks at the candidate drugs that have been touted as possible treatments for COVID-19. That on its own, if it's implemented properly, some countries, in Southern Africa do have legal provisions that actually prohibit the use of new patents. Patents, new uses of existing because of the nature of the Southern African Development Community as a region dominated by least developing countries. That window of opportunity provided by Article 31bis is there for Southern African countries to use. It is actually for them to use, and it's possible to now issue, if one would look at Article 31bis very closely, you can issue a regional compulsory license in order for you to supply, the drug demand in the region, as it were. And very importantly, what needs to be emphasized as a parting shot would be that if, in order for any eligible country to rely on Article 31bis, it really does not matter if the drug they want to procure is produced in that particular region or is patented in the country, a country requiring it, or a generic version of that drug exists. All possibilities, quite a number of possibilities actually exist on how to effectively rely on Article 31bis of the TRIPS agreement. So, colleagues, these are the issues I wanted to summarize and highlight. And the development community is better positioned than many regions, really. And if one were be allowed to actually add that even the other bigger regional economic community, the economic community of West African states, ECOWAS, the two regions are dominated by least developing countries. And the largest window of opportunity really is presented by Article 31 bis. The only West Africa and Africa generally is that despite the continent being dominated by least developing countries, a number of those least developing countries already have intellectual property laws that are pro-patents. And these intellectual property laws are fashioned alongside the lax requirement around patentability. And hence the least developing countries have actually limited their own ability to take advantage of TRIPS flexibilities. But we're saying that is not really completely a pessimistic view, because the countries can still wriggle out of these impositions they actually threw upon themselves. And I'm simply saying TRIPS flexibilities do present an opportunity for the region. The region can make use of it to procure medicines generally. As my colleague earlier said, that COVID-19 showed us why it is important for us to have a local production capacity of pharmaceuticals in our own regions. And the enabling environment is there. It is up to the region to make use of it through its own domestic interventions and through also regional interventions at SADC level. Thank you, colleagues. I think I should stop here, and if there are questions, we can take them. Thank you for listening.
Hello, can you hear me?
Yes.
Yeah, there is a question from, is it Marcela, which says, this week, South Africa and India presented a proposal at WTO for a waiver of IPRs for COVID-19 related health technologies. Could anyone in the panel comment on how this proposal is being seen in the region, and if other countries are considering to support this proposal at WTO?
Maybe you should go first, Chikosa.
Okay. I think the proposal is very useful at this stage, especially given that we would like to stimulate regional production of pharmaceuticals. The SADC region, which is thinking about implementing its business plan. So one would want to take maximum advantage of a waiver like this one. So my view is that this proposal is quite useful and is something that should be supported. And I know there's been some movement within the region to support this proposal. And I saw somewhere where CSOs are thinking about backing this proposal. Thank you. Maybe you can continue.
Yes, I can chip in, Chikosa, and actually say, from our side as academics in South Africa, we initiated a move where we want to push South Africa to actually lead Africa on that item, considering that South Africa currently chairs. We're actually very upbeat about this and saying maybe it would be, if it's pushed quite hard, it could be like what happened in Doha in 2001 when the declaration was pushed from an African perspective then. So there is that, upbeat spirit about the proposal from South Africa. And then some skeptics have also said, you know, it may be difficult maybe for South Africa to have other African countries rally behind it, because South Africa usually adopts a cautionary attitude. And some were saying maybe it would have been better if the request had been sponsored by a smaller African country, but not by the side. But we see this as a window of opportunity, something we should actually take advantage of. And already movement is happening, at least in academic circles in South Africa. We are actually in the process of putting something together for the attention of the president about the movement to show that we actually support it.
Yeah, is Tapiwa there?
Yes, I'm here. Lonias, can you please stop sharing your screen so that I can upload my presentation? Good morning, good afternoon again, colleagues. So my name is Tapiwa Chikujinga. I'm the director of the Pan-African Treatment Access Movement. I'm also an expert in intellectual property rights and access to medicines. So my presentation is going to focus on the pharmaceutical manufacturing sector in the SADC region. Sorry, Lonias, can you?
I'm trying to stop sharing. Yes, sorry.
Okay, thank you. Maybe let me. Look for my presentation. So, so the SADC region is actually made up of 16 countries, as Lonias mentioned, and these countries are listed there. I'm sure my screen is now visible. I will try to rush because of my limited time. And they are from Angola to Zimbabwe. We've got more least developed countries. Tanzania has just joined the other, groupings. And this is the map of the SADC region. So I don't propose to go through the whole sector because, I mean, it's quite big. We've got 16 countries. Most of them have pharmaceutical manufacturing capacity. But according to SADC, that's the regional bloc, the size of the regional pharmaceutical sector is estimated to be more than $3 billion United States dollars annually. So it is quite a large sector. And there is a huge demand for pharmaceutical products across the disease spectrum. The SADC region, in terms of HIV prevalence, is the most hard hit globally. We've got Swaziland, Eswatini, for example, which has got a very high prevalence, which is the highest prevalence globally. We've also got South Africa, which has the highest number of people living with HIV. And we've got a significant burden of TB, malaria. And then we've also got, the usual obstetric and gynecological conditions, non-communicable diseases, some neglected tropical diseases, and as many diseases as you can think about. So COVID-19 has added another layer to this demand because there's need for treatment, there's need for vaccines, there's also need for personal protective equipment. So I'll just look at 3 countries, which are South Africa, Zimbabwe, and Namibia. So I'll start with South Africa. So, but before I go there, I just want to point out that most of the pharmaceutical products in the region are actually imported from foreign sources. And these include India and China, as has been alluded to earlier on. So you find that it varies per drug or commodity. But for instance, the local production of HIV medicines is less than 15%. There's only one company in the region, which is Aspen Pharmacare, which has got medicines which are pre-qualified. You've got 2 other manufacturers in South Africa, which are manufacturing HIV products, but most of the region are not manufacturing ARVs. So South Africa has got the largest pharmaceutical manufacturing industry. It's got quite a substantial number of originator companies, which include Gilead, Roche, GlaxoSmithKline, Merck, Johnson & Johnson, Pfizer, and I think they've also got Sanofi. But it's also got a thriving generic industry. The Association for Generic Industries lists 23 members, but this also includes international players like Hetero and Cipla, Aurobindo, and Mylan. So Zimbabwe has got a total of 8 local manufacturing, pharmaceutical manufacturing companies, and all of them manufacture generic medicines. And all of them are small or medium by business classification because they've got annual sales of under 15 million US dollars per annum. So we've got Varicam Pharmaceuticals, which used to manufacture HIV medicines through compulsory license. It had pre-qualification in a number of products, but this has since lapsed. And according to UNIDO, in 2014, 15% of the medicines in Zimbabwe were imported. 40% were donated by either bilateral or multilateral partners, and 10% were locally produced. So it shows you that the local production component is very, very low. And part of the reason is because we've got antiquated equipment, as well as lack of funding and inadequate incentives, which contribute to the low levels of domestic production. And so when you go to Namibia, it's got a small but very robust pharmaceutical manufacturing sector. It's got 11 companies which are manufacturing medicines, but it's also got 2 multinational companies, which are Novartis and Pfizer, as well as a number of small generic manufacturers. But there's a company called Dow Pharmaceuticals, which started in 2014, but it's now gotten big in terms of market size. Through support from the government, technology transfer, and they got support to do retooling, and it helped them to start new product lines as such as condoms. And the company is now working towards GMP certification because they want to go into the export market. And as far as COVID is concerned, there's 2 COVID-19 trials, vaccines which are happening in South Africa. One of them is being done by the University of Witwatersrand. The other one is a collaboration between Pfizer and BioNTech. It's actually in phase 3. But we've also got one company, Aspen Pharmacare, which is manufacturing dexamethasone, one of the drugs that has shown minimal effect against COVID-19. So the challenges are many, but I'll just pick on a few. So the lack of advanced equipment to manufacture newer drugs is a huge challenge, but also the lack of skills. And this has led to the inability to manufacture some medicines. SADC has only got one vaccine manufacturing entity in Cape Town, but it's being hampered by lack of skills. Most of the SADC member states do not have incentives for local production, for local pharmaceutical manufacturers. And then the perennial challenge of access to funding, it's always a big problem. But there's opportunities as well. We've got a number of stakeholders who are working to reinvigorate the pharmaceutical manufacturing sector, and these include UNIDO, NEPAD, and GIZ. But also the significant disease burden that I've talked about presents a ready market for medicines. So instead of importing, we can actually manufacture. And there's also opportunities to scale up new product lines from the African Development Bank and the Afrexim Bank. So that is my presentation. There's only about 1 minute left, and I don't know that there is any questions. Thank you. So have you considered South-South cooperation to strengthen regional pharmaceutical production? There's a lot that is happening around this area. I can't give the details now because of the time, but yes, that is something that is actually happening now. Some companies are actually taking advantage of bilateral technology transfer opportunities that are available, and some of them are pharmaceuticals in Namibia is an example. There's a question about the waiver. I think this is for Lonias. Lonias, you could answer that one.
I've attempted to answer the question in the chat there, but I'm simply saying a waiver is temporary permission when there's an existing legal provision. You are seeking temporary permission not to comply with the legal provision with a view that, you know, by the time, at a later stage, you will be required to comply with it. And then a comparison license, we know it's basically you give permission to another manufacturer to manufacture what is patented, you know, because maybe the owner of the patent unreasonably refused to give permission, or they're basically, let's say in the context of drugs, the drug is too expensive, so the government permission can be granted. So it's compulsory in the context that the patent holder has not given you a license to do it. It's a compulsory license that way. Yeah, I think the waiver example one can use was one that applied to Article, it still applies actually. Article 31 when it was passed for the first time, it was a waiver where countries could then use it. And then when a number of members started ratifying.
Lonias, I think you need to wind up. We need to finish now.
Yeah, thanks. I think what I've just typed in the chat there will help. Thank you.
Thank you very much. Chikosa, would you want to have the last word before we close the session? Okay, I think Chikosa is no longer online. But thank you to all the attendees.